Well, good morning once again, and welcome to this segment of our breakfast meeting. My name is Dalton Kawesa. This segment, we need to talk about health. You know, it's a constitutional right for every member of society to be looked after by the government. And some of the things that we need to address are also the right to health. However, in the preamble of the Constitution of the Republic of Uganda, among the freedoms that are highlighted is accessibility to health services. How far is this being met is something that we need to have a discussion and a conversation. So many stakeholders have always come up to highlight the gaps and also maybe to laud the strides that the government has done. But while we talk about the strides, it's very important that we pay special attention to the gaps, because it is a right for everyone to access everything that makes them a healthy being. Well, with me is a very important person in this from the Center for Health Human Rights Development, and this is an NGO that fast tracks the health systems, the whole sector. And the lady here is the program manager and head of research from this very NGO. She's called Joy Asasira. Good morning and welcome to the breakfast meeting.
Thank you so much. It's such a pleasure to be here.
All right, let's roll the ball immediately. And before we go into the need, what are the health concerns this country needs to pay attention to?
First of all, maybe before we delve into the issue of the concerns, what is health? Because it might seem obvious, but not everyone knows what health is.
Please go ahead.
And it has been defined to be the complete state of physical, mental, and social well-being, and not just merely the absence of infirmity or disease. And so when you look at that definition, you find that health is very broad because it includes social aspects. Okay. But I believe that the key health concerns in our country right now are moving away from the communicable diseases, you know, the ones that are passed on through contact, and we're moving to the lifestyle diseases, where we see the issues of diabetes, you know, hypertension, cancer, and so on and so forth. But then there are also some historical, you know, health challenges that exist. And this is because of a number of issues, including history, you know, society, culture, but also, you know, politics, because health is very political. And one such health concern is the issue of sexual reproductive health and maternal health.
All right. You just highlighted something that maybe I want you to throw more light on. The lifestyle diseases, the way you describe them, it is something that is catching. Until recently, we need not have so many cases related to lifestyle. If you can break down for us some of these lifestyle diseases and why are we having them actually on our screens and on our lives, unlike previously, it would be very illuminating for the viewers.
Yes, I think lifestyle diseases, one of the things that we need to take cognizance of is the issue of globalization. As the world global, you know, the globalization takes place, we find that the issues of, you know, companies moving from, you know, the developed world, the so-called Western world, to Africa, where we have increased production. So that means there are more, you know, there's more air pollution, there's more, you know, workers or people who work in these sectors getting in touch with poisonous and noxious, you know, gases or other substances. But then we also have the issue of diet. You know that with more money and people becoming more affluent, people tend to move away from the organic foods and start eating the sausages and the, you know, the fish fingers. All this is, you know, they put lots of chemicals in there to preserve them and increase the shelf life of these components. But also because of globalization, people are moving away from the blue collar jobs, you know, the ones that involve manual labor and moving around all day and exercising your body and your muscles, which our descendants did a lot of. And you'll find that people will sit down, you'll come to office and sit down from 8 a.m. to, you know, 5 p.m. and sometimes even 9 p.m. because this is the nature of the corporate world. So in summary, those are some of the factors. Okay. But also lifestyle. No exercise, really. Yes. The conscious choice to do some exercise.
You're speaking to my producer right away about exercise. Yes, the right to health is important.
Very.
A lot of misinformation is out there. and people have given up. People that try to access health services, health centers, and they do not get the drugs, they tend to look for alternatives.
Yes.
They would go to traditional healers. Why is it important?
Why is it important for people to access medicines?
No. Why health as a right?
Yeah.
What should be? What is the tale about health being a right?
Yes. Health as a right, I think, has been defined as, the right to health has been defined as one of the vital components for one to have an adequate standard of living. Because if you look at life, you need many things. I think in primary school we learnt about, you know, the essentials of life, food, shelter, education, but health is also in there. And maybe to go away from being academic, one of the factors that brings everyone across the board, you know, that shows our fragility as a human, you know, as a human being, is the ability of the body to break down, our predisposition to disease. So when you look at that, then you start thinking, shouldn't these health services, because we are all fall sick, we all need health care, shouldn't these services be a right? And number one, shouldn't they be accessible for everyone equally, without others having to experience more hardship or more expense than others in terms of accessing these services?
What is the overview of this right? People know that it's their right, or we're still in the dark age where people don't live the day as it comes?
Fortunately, I think I'd like to laud the government, as you said, and also stakeholders, the civil society and you know, development partners. A lot of sensitization has taken place. People know that they have the right to health. That is why you see, I think NBS also airs these stories where, you know, a community will rise up and go and challenge, you know, the in charge of a clinic or a hospital or a health center and say, why are you arriving at this time? You owe us a duty to arrive in time. You owe us a duty to ensure that the medicines are, you know, in place. You owe us a duty to ensure that the midwife or the doctor that you promised us is at the station as they are supposed to be. So I believe that there is an increase in a recognition of the fact that the right to health is indeed, you know, inherent, that you have it by virtue of being a human being, and it's not a favor that anyone is doing you.
All right, we've heard that the government has always come out with statements, and more often than not, we've been told that they are political statements about the drop maternity rate. And since you have a bias in this, by the virtue of the organization you represent, you have a bias in health. What is the situation? What is the status in maternal health?
I'd like to, for once, side with the government. I don't think it's a political statement. Indeed, I think, as someone said, let me first start by saying that someone said that there is no single cause of death and disease for men who are in the reproductive age that can be compared to, you know, pregnancy-related diseases and death for women of reproductive age. That being said, the government has also taken cognizance of this. And even as you started, in our constitution, Article 33.3 talks about the unique state, you know, the unique function, the unique maternal health function of women, and recognizes this, and the need and the obligation of the government to put in place facilities to enable these women have their babies and be healthy, and the babies also are healthy. So the state of maternal health has been improving. There is no doubt about that. But maybe the challenge is it enough? Are they doing enough? Because we still see an issue of health workers. You know, we know that attended deliveries, or the women who go to deliver in health facilities, are still below 60%. That is not good, because we know that that means automatically, even though every pregnancy carries a risk, these 40% or more who are not going to the health facility have a higher chance of a negative health outcome as they deliver.
We just recently celebrated the Midwifery Day.
Yes.
Some of the things that came up was the burden onto the midwives. They're actually overstretched, and they're even very few. From what I read from that angle, I don't know what you people, either in terms of sensitization, what has been the tell? What has been your evaluation of the role of these midwives, and in quest to push a proper handling of these pregnant women?
Yeah, history and evidence and science are on the side of midwives. If you want to improve maternal health, midwives are the main who, you know, who can play this role, because we know that the doctors are few. Midwives can be trained faster, and they are able to be recruited, you know, to be deployed faster because of the length of the training, but also because they don't require to go for those advanced trainings of surgery and whatever. But as you've rightly stated, midwives are still few. I think we have a ratio of about 1 to 11,000. So 1 patient to 11,000 midwives. We are doing badly.
That's too bad.
It's too bad. But our government is cognizant of this. And I think in the last financial year, there was some money that was allocated to recruitment of midwives. But the challenge continues to be that these midwives, even when they're recruited, the working conditions are difficult.
Okay.
Beyond the you know, the heavy workload of how many women they have to attend to, we know that the commodities are not there. You know, the story of the maternal, the mama kit, the mama kits are not in the facilities. We've seen these stories day in and day out where the midwives use a torch in their mouths to deliver babies, where she touches in her pocket.
And that is in Uganda?
In Uganda, where she touches in her pocket to buy a glove, to buy, you know, some of these essential commodities that need to be in the facility already. But we also know that the pay is low.
All right.
You know.
But maybe as you push for the increase in the pay, and you people in the civil society also need to touch on the issues of the sexual reproductive health and the rights. There's a lot of ignorance that is out there, and it profits me and the viewer. What is the stake as we speak in terms of the sexual reproductive health?
Yeah, sexual reproductive health really is about you know, the functioning of the reproductive system. And when we talk about this, there are a number of services that are contained under this. Issues of family planning, issues of, you know, the reproductive tract, cancers that affect the reproductive tract, adolescent sexual reproductive health, fistula, maternal health as well falls in there. So when we look at sexual reproductive health, we see that a lot is at stake. Let me take an example of adolescent sexual health. We know that the majority of the population of of Uganda are young people. But if we are not prioritizing their health, if we are still having, you know, as a point of reference, morality and religion in making of policies for young people, you know, when they say 10-year-olds are going to access family planning services. And remember, family planning services means information and the commodities themselves. So no one has even said that they are going to access those commodities. But can we start giving them information? People rise up and say, no, we are a country that is religious. Then we have a challenge. Because we see that the policies are sort of being sometimes, or the practices and the programs are being side-railed by issues that are not based on science and evidence. But I want to touch on another sexual reproductive health
maybe
issue.
if you go there, how is morality, or let's call religious dogma, affecting the sensitization in the realm of sexual reproductive health?
It is, I think, one of the hugest challenges we have.
How?
Because when we look at progress that has been made, it has been made because there has always been, for any country, across the board, globally and in sub-Saharan Africa, for countries that have made progress, South Africa, for instance, evidence and science should be the single basis on which a policy or a program should be.
Okay.
But in Uganda, it's not.
We measure it somewhere else.
No, we have the statistics and they speak for themselves. But because, you know, we have, and unfortunately we're not even a religious country, we are a secular state and our constitution is very clear on this.
We're a conservative society.
We are conservative, exactly, but we are not a religious country.
Okay.
But people confuse those two things. And so when you even come to the table to start discussing policies and strategies and programs, people say, no, we are Christians, how dare you? But remember, that's not a basis. The facts are there, the statistics are there. The pregnancy rate, teenage pregnancy rate has gone up. It might be a small increase, but that is a telltale sign of the, you know, the future that is to come that we don't want to see.
Okay, and what are other aspects of reproductive health that you need to really highlight in this?
Oh yeah, I want you to highlight the issue of unsafe abortion. Most people don't talk about it because obviously it's very contagious, it's emotive. But if we look at maternal health, as we talked about, maternal health is improving. But are we as a country doing enough to address unsafe abortion? Abortion is highly restricted in Uganda, but that does not take away the role and the duty of the government to ensure that our women and girls do not die from unsafe abortion. We know that about 25%, 26% of the women from pregnancy-related causes, 25% of those are due to unsafe abortion. But we see that this is not something that's been talked about. And it takes us back to the previous point of religion and culture. People are looking at it as a religious moral issue, but it's really a public health issue.
But the
It's
laws,
really a gender issue, and it's really an issue of science.
Joy, why? Because the laws, the current legal regime
Yes.
allows abortion in certain instances.
Yes.
Hasn't that been good enough to address the challenges?
But you see, if the law is there, because the law, as it was framed, has two roles. One, it is to prevent unqualified people, you know, from doing those unsafe, doing abortions. But it's also supposed to enable the women who qualify, you know, to access the services. But if there is a lot of stigma, if this provision of this service is not being treated like other health services, because it's given a status, and you'll find that there's always a lot of, you know, debating and bargaining, and that's why you'll find that many times when a woman dies from an unsafe abortion, whether or not she had come into the facility to complete the procedure, she started elsewhere clandestinely, the police will swoop in and arrest the what? The health worker. So it creates a stigma and you know, misconception on the issue, whereas it's a health service.
Yet people are even becoming hesitant to help when they need to help the health workers.
Because of the different, you know, complexities around that helping. Because if you're going to be arrested as a health worker, why would you bother?
How do we break the barrier?
I think a lot of sensitization. And I think like any other health challenge, I think for HIV to be addressed, what happened was the stigma was lifted. The veil of stigma was lifted. And then people started discussing HIV as a health, as a disease. You know, that could, you know, that had strategies, that there were evidence-based strategies that could be used to address it. And now we see that the prevalence rate is you know, stable, is going down.
All right.
But then that needs to also happen for unsafe abortion.
Well, whether the debate will be or whether on moral issues or social or the religious dogma as Joy presents it, it's something that really ignites debate. And well, I welcome people to debate it. And as a nation, we need to have this conversation at our people, especially the young age that is getting sexually active, and we're just keeping our eyes away from them. Yes, Joy, there is this thing called maternal morbidity. Yes. I've met it, and many people ask, and I am asked that you are in the right position to answer. What is it when they talk about maternal morbidity?
Maternal morbidity really talks about death that occurs that relates to pregnancy. And this, the timeline within which one will be said to have died from have a maternal morbidity is 42 days after the pregnancy happened, or after the woman gave birth. Yes.
Okay, then what explains? We're talking about the reduction, but it's still there, right?
Yes.
What explains this?
There are a number of things. I think as...
Before I even answer, we have improved as a country.
We are improving.
We are not where we were, let's say 30 years ago.
No.
And the sensitization is also very high.
True.
We have improved, let's say, the capacity in terms of health workers, and maybe even the reach to the health services. But this is persistent. And how do we address it? And why is it persistent?
I think, as I had already told you, some of the programs that the Ministry of Health is doing are really targeted towards, first of all, ensuring that the women attend the recommended 4 ANC visits, the antenatal care visits. But women don't go. When it was the first time I find that I'm pregnant and I'm fine, she won't go back again. But it's because of other factors, really, finances. That's where that would take us into the discussion of the universal health coverage and ensuring that there are services available for all, free services. But that's another discussion. So we'll find that even when it comes to time for delivery, the women will not go to the facility. I told you less than 60% go and deliver in the health facility because they don't have money. They don't have the kasuka for the baby. They don't have the, you know, nice maternity dress. They are not feeling, you know, like they deserve that service, because sometimes we know that the health workers have also said, oh, you're really dirty, or you're not in a good state. But those are also things that can be addressed through sensitization. They've
also had very loose comments from loose comments actually attributed to health workers, especially in face of pregnant women. Yes. And that, in a way, is detrimental to these checks. Okay, as Center for Human Rights and Development in the health sector, somebody is going to ask, why the interest in this campaign?
Why the interest in maternal health?
Yes.
As I started and said, that it is a fact and it is known that there is no single cause of death and morbidity or disease, death and disease, for women of reproductive age for women of reproductive age, like pregnancy-related deaths, as compared to men of reproductive age, because they don't have that challenge of dying because they are giving birth. So for us at Center for Health, Human Rights and Development, taking that into account, and also that started as an organization in 2011, there was no day that you'd open a newspaper, that you'd turn on your radio and not hear that a woman died. And why did she die? There were no gloves. There was no blood for transfusion. The health worker was not in the facility. Most of these deaths are preventable. And we are saying, fortunately, and we are saying to our government that why don't we focus, why don't we prioritize, put resources, put the health workers there, put in place programs, policies, so that our women don't die. And then we'll have a productive workforce. Well,
most of the things you've been accused, especially people in the in civil society, is that you have not demonstrated how capable some of these things are. And majorly you speak about these things because maybe you want to attract funding and name it. It brings me to the question, Joy. What tangible issues or aspects should governments touch in order to turn this whole maternal health around?
It's quite, like I said,
as we conclude,
the things that our government should touch are really overhauling our health system. The health system has a number of building blocks, and this doesn't only apply for maternal health. We find that if our health system is overhauled holistically in terms of these building blocks, which include human resources for health, the leadership and governance of the health system, the availability of the commodities and the medicines, the information, or can I say IT, the technology, we will find our health system will be self-sustaining, that the progress that we're seeing is going to be sustained or even increased. And one of the building blocks, by the way, is also the human resources for health. So if we focus on overhauling the health system as a whole, and that's why I Center for Health, Human Rights and Development, people always ask us, why aren't you running to help this young woman directly and help her with the facility and deliver? That is a good approach. But when you target systematic issues or systems issues, when you target when you use strategies like litigation that we use, that is targeted towards addressing the system as a whole, then everyone in Uganda benefits.
Okay.
Yes.
Thank you very much, George Asasira from Center for Health, Human Rights and Development. She has been touching some of these subjects that actually many people fear to touch, the issues of social dogma and things that we need to break away from society and keep away those barriers such that we keep a healthy nation. Remember, health is we shall keep this conversation on our social media platform at NBS. My personal handle is at Dalton Kawesa. And your personal handle, Joy?
At J Asasira.
At J?
Asasira.
J Asasira. If you please, you can get in touch with her. In any questions at here at NBS, we shall also commit ourselves that we shall invite her more often to break down some of these issues that many do not understand. My name is Dalton Kawesa. Yes, thank you for being part of this great audience at the command center. We say, keep it here. Good morning.